up. Oh, this is before the housekeeping items. So we will be recording this meeting for the entirety. So I hope everybody is okay with that. So we are sharing lessons learned during implementation of the Mosque PCOR toolkit, and this is primarily, particularly with respect to DuPage County. Okay. Okay. The format of the town hall is such that we have 4 segments. We have the mosque community. The first segment focuses on the mosque community contributions and how the Muslim Society Inc., which is the mosque on Bloomingdale Road, how they have contributed during COVID and before COVID. Then we will go over, we will have a brief overview of the Mosque PCOR toolkit and what that entails for the stakeholders. And then we would have the data, Virtreach data presentation. This is a virtual outreach data presentation by one of our study participants. And then there will be an open discussion. All the talks are small segments and comprised of for about an hour. And the panel discussion is dedicated for an hour. Just a few of their housekeeping items. All participants are mainly in the listen only mode. The chat is open for questions and comments. The chat box is moderated actually by me today. Everyone can mute themselves until the open panel discussions, and panel discussion will consist of specific questions for the first round, and then anyone can participate after that. And now I would like to request our brother Saif, Muhammad Saifullah, to recite a little prayer. We always start with a prayer, but the best part about it is that we add an intent to our prayer, which means we really would intend to do this, as we have learned that many things with the intent actually comes out to be true. So Saif, go ahead, please recite our dua. We can't hear Saif. Hold on, Saif. Hang on just a second. Go ahead. Right? Hold on.
Okay, Saif can go ahead now.
Okay, Saif can go ahead now for the dua.
Hey, can you hear me? Hello?
Yes, now we can hear you, Saif.
Okay, good afternoon. Assalamu alaikum, everyone. I just wanted to thank everyone for all the great work. This is truly a special project. So I hope everyone will continue to be involved and support it. And I'm very honored to be here today. So we'll start off with the prayer. And the intent for the prayer we can sort of think about is that we're talking a lot about health. So, there's a lot of emphasis on physical and spirit and mental health, but we sort of tie it in to spiritual health with, and an example of that is this particular prayer. So I'll recite the Arabic and then the English. Allahumma rahmataka arju fala takilni ila nafsin طرفة عين وأصلح لي شأني كله لا إله إلا أنت. O Allah, I hope for your mercy. Do not leave me by myself for even the duration of an eye blink, and correct my total condition. Besides you, there is none worthy of worship. Ameen.
Ameen. And Jazai Khairan Saif for the beautiful dua. And inshallah, with that intent, we begin. Before we get started, we'll like to do a little poll. And I think Masood is going to launch the poll right now, which has these basic questions. And if we just take a few moments to do the poll, that would be great. Host and panelist cannot vote. Can you do the host and panelist can vote too? And we can. No? Oh, okay. Host and panelist cannot vote. So go ahead and So I would have loved to hold the panelists too. Oh, it doesn't allow us? Hmm. By the way, this is the first time we are running this poll on the Zoom. There's a learning curve. So bear with us as we experiment these things in the live mode. Thank you so much. I don't know, maybe this is not working. Huh? Yeah, but I don't know if it's, can you take the poll? Oh, okay. But other people are not. Okay. Oh, unable to submit. There are some technical issues. Okay, Steph just sent the responses. Yeah, Nancy's unable to submit, so I don't know. There are some technical difficulties with that. We'll take it whatever we get. So primarily, the whole idea is just to get some basic idea as to how people relate to the patient-centered outcomes research project and that entire body of knowledge, and then whether we are ready to take this forward with our work or not. So just to give you a little bit background about the, can you do a chat?
Yeah.
You know, I wanted to have, yeah, I don't know what happened to the slide. Okay, so let me introduce you to Dr. Rebecca Johnson at this point, who would be our host for this town hall. And Dr. Rebecca Johnson is actually, right these days, she's a freelance researcher. She has specializing in research participation and facilitation. She actually came to us from Northwestern University and being a social scientist. And I met her in the previous PCOR project and loved her attitude and how she worked and how she has this comprehensive way of looking at community with all the different cultural aspects, including language and behavior and attitudes and the positivity and some of the needs and the biases. So it's just a beautiful way. It has been a beautiful journey for me to personally to work with Dr. Johnson. And I wanted this particular panel, as rich as this is with all the panelists and the participation, I personally could not do it. And I asked Dr. Rebecca to please host this for us because of the richness that you all bring to this panel. I really appreciate everybody being here, and with any further ado, I want to give this to Dr. Rebecca to take it forward from this point on. Dr. Johnson is unmuted. Dr. Johnson, you're muted. Oh, by the way, I got to tell you something about Dr. Johnson. Because of what COVID has allowed us and what we have come forward with all the virtual environment, Dr. Johnson is working from England these days, and she has this beautiful icons from England. And I want to take a few minutes to have her tell these stories, especially that pump in the background.
That's right. Hi, Fatima. Sorry about that. We're good to go now, so we're unmuted.
Thank you.
So yeah, hello everybody from the United Kingdom. So I'm very pleased to be here and helping Fatima by moderating this session. And yes, I wanted to share with you some images this is actually from London, and it's a whole series. I've been going around London and looking for public health monuments in London, and the pump actually to my right, yes, is actually in one area of London where they discovered there was a very big case of cholera. This is back in 1854, and they didn't know why. They just didn't know why it was there. And so John Snow, who is the name of the pub behind the pump, he basically started mapping out the area, and he worked out where the cases were of cholera, and he realized that it was all the biggest constellation of cases was around this pump, and so they stopped the water at the time. So I thought, yes, I wanted to share that with you. So 1855 mapping, collecting data. These started the public health movement, and I know since when I worked at Northwestern, that university was set up in response to a public health epidemic as well. So it's very important, and it's a global issue, just as COVID-19 is now a global issue. And mapping, research, finding solutions has always been a key part. And giving you some background to today's talk, researchers have not always been very good at finding the right data. I mean, the data we collect is only as good as the questions asked. And I think many people are confused about what researchers do and what their role is, and they often think that the research isn't relevant to them, and therefore they feel, where is all this money going? What is it being spent on? But one of the things, when I first came to the States about 10 years ago, the way I got to understand the healthcare system was actually through joining the Patient-Centered Outcomes Research Institute. And this was happening at the same time that the Affordable Care Act was passed. And the focus of the Affordable Care Act was on expediting health equity. The focus of PCORI, the Patient-Centered Outcomes Research Institute, was providing the evidence to back up or to help those delivering the Affordable Care Act to truly understand the interventions and the options which were being made available were evidence-based, and that they were representative of America, everybody in America. So that the research wasn't just with one group or another group, it was with all groups, and the focus was on treatments, options, healthcare services which could benefit particularly communities suffering from health disparities, or patients living in communities where health disparities and health inequity was high. So I've been very passionate supporter of PCORI right from the beginning, 10 years ago. I think it's an amazing institution. It's got a real vision, a real mission, and it really was, to quote the one of the founding doctors, the goal was to change the way research was done, to make it more relevant, more representative, and ultimately to improve the quality of healthcare that people were getting, and their experience and their access to it. Now, since then, the National Institute for Health has also become very involved in sort of focusing on expediting health equity. And there's a big movement now called the Translational Sciences, which actually is the one place where Northwestern, the University of Chicago, UIC, they work together on translational sciences to joint projects. They each have a center which focuses on translational sciences. And this is the translational science, is the process of turning observations in the laboratory, what we often call the bench, into but going beyond that. So it's not just observation, it's not just the bench, it's not just the lab, it's also the clinic, observations of what's happening in the clinic and the community, and working together to create interventions that improve the health of individuals and the public. So we're moving away from the idea that research is bench to bedside, to hospital bedside, to the idea that research is something that is responsive to everybody's needs, the health of individuals and the public at large, and is particularly responsive to any areas of communities where there are health inequities. And as has been evidenced in COVID-19, those inequities are very clearly visible now through mapping. So I thank Fatima for starting with a poll, because funnily enough, we all do research. We all do research on a daily basis. If you're sort of, you're wanting to buy a car, or you're wanting to sort of, find out, buy a present or anything like that, you're doing research on a daily basis. People are often asked to do customer service surveys. It's part of everybody's sort of everyday activity, but it's still seen, I think, unfortunately, as something a little ivory tower or elitist often, and not relevant. And so just to a poll really is a nice gentle way of easing you into that question, because research is basically about looking into something to find something out. I think it's a nice way of thinking about it. And a general poll like the one that Fatima and the team put together was an attempt really to ease you into the world of the acronyms, the abbreviations that are so prevalent in the research world and in PCORI's world, even though it's very focused on people and communities, and the mission is very focused on helping people to make informed healthcare decisions and improve healthcare delivery and outcomes. But it is all about collecting data. It is about collecting data, and in order to create evidence-based information that is relevant and comes, so that we create research questions, and then rigorous methods, but we're guided by reality and the real experience of patient caregivers and the broader healthcare community. So that is the PCORI mission, and it's about accelerating the impact on care and patient-centered outcomes. And patient-centered means the focus on the individual. It can also mean organizations who represent individuals. And that is one of the weaknesses, I think, if we're going to sort of think about it. PCORI doesn't really use the word community. It has this idea of the focus is on the patient, and sometimes the caregiver, and the healthcare systems, patient partners, could be training institutions, policymakers, researchers, but the idea of community is still is something I think that also that researchers are struggling to work with, because everything about the healthcare system is so focused on the patient and patient delivery. So if we go to the next slide, PCORI, very strategic, very focused. The five pillars of a PCORI strategic plan are engagement, methods, research, creating a comprehensive agenda of high quality patient-centered outcomes research, and keeping ongoing in terms of evaluating impact. Dissemination, which is a word very familiar to researchers, but won't necessarily is not used widely. But that's really about communication. That's about getting the outcomes research to everybody, and helping support its uptake and implementation. And then the idea of infrastructure, because one of the saddest things about research often is it only lasts between 2-3 years, at most 5. And so often things are done, really exciting ideas are done, but there's no way of sustaining it or building on it or taking it to the next step. So these are the 5 imperatives. And the one that I've been working a lot on with faith-based community organisations, including Pastors for PCOR and also Fatima at Worry Free, is engagement. And this is, again, a little bit alien to researchers. It's not something that we would naturally think about engaging, which is bizarre in some ways, and actually think about engaging patients, caregivers and other stakeholders in the entire research process, from asking the question to communication and then implementing results. But that's PCORI's, that is one of the unusual things about PCORI, is that focus on engagement. It's unusual to think about research engagement as well. And indeed, I find it very difficult to explain what research engagement is when communities ask me what it is. It's actually very hard. And most research doesn't actually engage patients and caregivers other than through recruitment. So people become part of clinical trials. But this is research which is trying to get everybody who is using the system and experiencing the system together at the table to create questions, to be in at the question making stage, and then also the methodology, and then later down to the results and sort of sharing and communicating what works for them and communities, and helping implement results. So all the way through the research process, the idea is that patients and caregivers should be engaged. So the purpose of today's town hall, which is often, as I said earlier on, faith-based communities are often slightly at the edge of the patient-centered initiative, because they focus on community health in many ways. And so what we want to do is we want to foster a culture of engagement between the mosque community and the healthcare system through building partnerships and coming up with co-learning opportunities. But those need to be culturally sensitive, they need to be respectful, they need to be an understanding of the mosque community, and also the mosque community. There's a whole new language to learn about treatment options, health options, and that can be very daunting. But there are some great examples emerging at the moment, and I think 10 years on from the establishment of PCORI, there's some really, really good examples of the ways in which patients as members of communities are being involved in the healthcare, in the development of research which creates a better healthcare system. So today the focus is on thinking about patient partners, and I think we're thinking of that as both individuals, but also individuals who are part of communities experiencing health disparities, and individuals who also pray and are part of faith-based communities. And this PCORI has been great in it's funded the Mosque PCORI Toolkit, it's funded the Pastors for PCOR Toolkit, and these are all methods to get people involved in research and make sure that the research is relevant for local communities who are experiencing health disparities. So I think, okay, I think the next segment, Fatima, do you want to introduce the next segment?
Yeah, so the next segment, we would actually go to the mosque contributions for the communities. And Brother Abdurrahman, who's going to be very soon, he would be titled with the Dr. Abdurrahman Bahri, would be, he was a participant with us at this study, and as a community health worker. And he has worked diligently with that community, with the MSI community, to put together this in the next slide presentation for us. Go ahead, Brother Abdurrahman.
Okay. Well, hello, assalamu alaikum to everyone. Thank you all for being here. So I'm just gonna give like a brief background of what MSI is and what they do for everyone. So MSI is located in Glendale Heights, and it's been around since the early 1990s, and it caters to over 1,000 people. And so MSI not only functions as a mosque, but also as a community center for all the Muslims in the area. So it holds 5 daily prayers and Friday sermons and lots of other activities that you'll learn in a few minutes. So the whole goal of MSI is not only to be a mosque, but also be a place for all the community members for you know, spiritual growth and health related activities and education. So can you move to the next slide, please? So MSI has is part of lots of activities. So I'm just gonna highlight some of the big ones over here. So some of these are zakat, which is basically like a fund for the needy people in our community. And they also hold funeral services. So the mosque helps and supports the families through the grieving period, and also the proper like Islamic guidelines for burials and emotional support as well. And then there's nikah and marital services. So the mosque facilitates the contract of marriage and also counseling and other marriage-related services. And so there's lots of educational activities in the mosque. So there's after-school programs for children, there's summer school, there's a weekend school, and all of these are they're focused on engaging the community, engaging the children, and making sure they stay connected to our religion and the Quran. And it's a place for children to have fun and make friends as well. And then there's also lots of youth engagement programs like sports. So sometimes MSI holds like these basketball tournaments for children. And then there's also a HIVS program, which I'm also a graduate of actually. And so this HIVS program has been around since 2006, I believe. And yeah, so it's been around for a while. And there's also food pantries and services for those in need, so financial support and housing and anything else that they might need. So MSI facilitates these needs for these people, and then also health related needs as well. So they'll connect the people in need to whatever services that they need. So in COVID-19, not a lot was going around in the beginning, but then slowly, when we got a hold of what they could do, MSI started reaching out to the community again. And then so they were part of a bunch of activities. So some of these were, they held COVID testing sites in the parking lot of the masjid. So that happened a few times, and it was open to everyone, not just the Muslim community members. And also they partnered with the Worry Free community, and we had a couple vaccination events in the basement of the masjid. And then they also held lots of food distributing services. So those people in need, they could actually come to the mosque and every week they had a food pantry where they would distribute food to whoever needed. So can we go to the next slide, please? So a lot of hurdles were faced for the mosque. Sorry, I'm reading off my notes here because I'm not very good at talking off the top of my head. So, okay. So obviously social distancing was a big problem. It still is right now, but we've learned how to, you know, work around that problem. And so one of the big things is social distancing in the prayers. So especially in large prayers like in the weekly Friday prayers and Ramadan and Eid. So these prayers, they usually host around 500 people. And obviously during COVID, you could only have about 50 to 100 people. So this was a huge problem for MSI, and we had to work around it. And so we had to, talk to the Golden Heights community, and we had to work away around that problem. And then there's also lack of communication from a lot of the attendees, the normal attendees that were in the, oh, sorry, I'm jumping around slides now. But yeah, so there's a lot of lack of communication, and lots of attendees, we couldn't communicate with them. So we had to start like different, think of different methods to communicate. So we used social media, there was WhatsApp groups, there was Facebook, we had Zoom meetings, and yeah. So there's a limited attendance in the mosque. So this also led to lower funding, lower donations. And so this was a problem financially for the mosque, and lots of youth and adults, they couldn't participate in the activities that they were usually used to. And yeah, so can we go to the next slide? Okay, so what are MSI's future goals now? So what MSI's goals is to increase the memberships and increase the attendance of the mosque again to what they were pre-COVID, and also increase participation in the activities like after-school programs and other educational programs, because this has taken a huge dip now because of COVID, because of social distancing, and people don't feel safe. And there's also volunteers. So we have a decreased number of volunteers. So we would like all of that to improve over the next few months and by next year. And then, so we would also, also increase enrollment for programs like the food banks. And we want people to engage with the community outreach. So like newsletters and the social media outlets that we established through COVID. So we want people to be more active in those components. Okay, so throughout COVID and this project, we had a bunch of like events and programs where we try to engage with the community. And so these, all these things, they included the P-Core principles that you'll learn about a bit later. But I'm just gonna highlight a couple of these principles right now. So just as a preview, so some of the P-Core methodology for engagement include reciprocal relationships, co-learning, establishing partnerships with community members, and transparency, honesty, and trust. And so we incorporated these into a virtual outreach. So we wanted to keep the community engaged and also informed about COVID and any other health related issues. So we set up this hotline, and then in this hotline, and we set up a website as well. So there's a hotline and a website, and anyone can reach out to us through these this number and the website, and they can ask us questions about anything health related. So it was not just health related, it was more than that. But just to keep it simple, it was stuff like COVID. So lots of people wanted to know where they can get the vaccine. And so we helped them find spots where they could go and get the vaccine, and then also insurance and financial support and anything health related really. And then we had a Ask a Doc series where we just answered, we had a doctor come in, and then on Zoom, we had a community town hall, and we had them answer any questions about COVID or any other health related topics that people want to know about. So yeah, that's it. And these are the two flyers that we used to that we distributed through the community. So we printed these out, and we, posted them in stores and restaurants and in the mosque, and we emailed them, put them in WhatsApp groups. So yeah, that's about it. Okay, so I think I'm gonna hand it back to Dr. Johnson.
Okay, thank you very much. Thank you. It's really, really interesting to hear how the MSI sort of basically responded to COVID. I think that's really, really, really interesting, and how you're planning to take things forward and think about the collecting evidence about the new operations that you're putting into place. So one of the things that we did as a group is, before the members of the group sort of got engaged and with the mosque communities such as the MSI group, was we talked through the Mosque PCORI toolkit. So we thought through the process of engagement, and this is a little simple diagram of how the process, the research process. Sorry, this diagram in the middle, the Mosque PCORI toolkit. It's got this lovely diagram, this circular diagram. Perhaps you can go back to the other one. So yes, so there's the scientific research methods. So we've got, we needed to understand those as a group before we could contact the mosque communities. Then there's the mosque communities, and we needed to understand the mosque communities and how they operated. And I think Abdurrahman has done a great job of giving you a sense of how they operate. So there's with some of the specific things. So there's the idea of providing funeral services, there's the idea of providing food, there's the idea of providing support and education. So these are all things that possibly could be provided by mosque communities, but what I learned is not all mosque communities are the same. And so I think it was very important for us to understand the operational the organizations as well. And then there was project management, and so we talked, and Fatima and Nabil led the way on helping the group to think about how to make that first foray, as it were, and to meet and think about. We talked about who to meet. Would it be the leader? Would it be a committee? Was there a need to set up a board? What would people need to know? Information that people would need to know about PCORI. I mean, as I mentioned before, patient-centeredness is not a word that is in every part of everyday language. Research engagement is not part of everyday language. So there's an awful lot to negotiate. And of course, during COVID, as Abdurrahman has so well explained, a lot of things shut down. So this was not necessarily a great time to try and engage people with research. I mean, and as also beautifully illustrated, there were so many other things which had bigger priorities going on. But we all felt passionate about the fact that there was something here, that there was actually something very important in terms of partnering, particularly actually in a time of COVID, because it's about finding out what the research of the future should look like, how that should be articulated. So the answer to the question is, what is the MOSC toolkit? It's a toolkit for MOSC-based I can't, you're going to have to go back to the slide, sorry.
Oh, sorry.
Yeah, that's right. A toolkit for MOSC-based patient-centered outcomes research. And remembering that patient-centered outcome research is about patients in the community, in the MOSC communities, who their needs, their experiences, and their questions. Okay, so moving forwards. So the development of the toolkit, this was actually started in a previous project called Engaging Muslim Americans for Research on Community Health, codenamed the eMarch project, and that was led by Dr. Padella, then he was then at the University of Chicago, and in partnership with Worry Free, and he began to work out what the key issues were for mosques. And obviously this is pre-COVID, so the time frame is very important in terms of moving forwards. But he was working out what the health conditions were, the priority health conditions were, what were the almost like the key features that would be needed in order to engineer engagement, effective engagement. And I think, what researchers would have to do in order to think through that engagement in respectful ways, transparent ways, given that we have this burden of language, which is quite difficult to unpick and to explain. And I don't mean, I'm not talking about English, I'm just talking about the language that researchers tend to use all the time. And they are familiar with, but they are difficult because they're often conceptual terms rather than being practical, focused, pragmatic terms. So the MOSC PCORI toolkit was the results of talking to imams, I believe, and coming to take a result of a conference at which there was an initial agreement of the foundation of the key things that were needed in order to help mosque communities and mosque community leaders work with researchers on issues that mattered to the Islamic community. And then, so this project is very much about the dissemination of that toolkit. And so we're called MPART, which stands for Equipping Muslim with PCORI-based action-orientated research tool. So we were tasked with putting the concepts identified as being core into action. And that really is the birth of the MOSC PCORI toolkit. And I think Fatima would be the first to say is that turning something into reality, concepts into reality, is very difficult. And finding out, and given that organizational contexts are very different as well, working out what works for like MSI isn't necessarily what's going to work for other of the mosque communities that have been involved. But I have to say that the community health workers who were engaged and who took part in the training we put together, which was trying to work through this toolkit, were brilliant. And they are the ones in the end who have translated how those initial activities and concepts have been translated into action. Fatima, do you want to add to that?
Yes, that's what I would definitely second that. That it was a gruesome reality for myself as well, because I thought, oh, we have this now. We have a blanket method to apply to any mosque community you go to, but there are nuances. There are something that works for one, it doesn't work for the other, and we also found out that that also has to do with the federal poverty levels as well in different communities. And so it kind of matched with the rest of the faith-based community. So that was an encouraging thing to know, that what is working for one particular ethnic group perhaps may work for the other ones as well, but when it comes to federal poverty levels. However, those cultural standards do stand. And again, the community health workers, who actually are a bunch of younger generation, I have to say, because we picked the cohort with respect to when they got right out of the college or their professional degrees, and half of them actually finished their medical school, then the other half was a public health administrators. So we have a combination of that, and now they are, with this 1 year's worth of community health background, they are now advancing into furthering their career. So they really did a very good job in taking this and translating that into action items. So thank you. Really appreciate that.
Yeah. Yes, me too. So yes, so what the content in the original in the toolkit, the key concepts which Dr. Padella and his group highlighted was the importance of community-based participatory approaches in mosques, which means really engaging. Community-based is not quite the same as patient engagement, because what it's really looking at is it's sort of wanting to, it's not just the patient, it is actually the finding out the group as a whole. So it's not just people with a particular health condition, like advocates for patient advocates. It is the whole, it's the context, it's the whole. But he also identified patient-centered projects as important as well. So they could be, and in particular, I think Dr. Padella has published on cancers, and he's looked at sort of issues, particular issues facing women's immigrant communities and health around that. So patient-centered would be very much people receiving care for and treatments for cancer. That would be an example. So he also highlighted the PCORI life cycle versus the project management life cycle. Fatima, do you want to clarify that?
Yeah, so PCORI life cycle, yeah, so the project management life cycle, actually most people are familiar with. And in fact, most of the mosque board members are IT professionals or business folks, and they have very familiar with the project management life cycle, and they know it. But how do you take that and use it into the context of patient-centeredness? And PCORI has its own life cycle, which is 3 phases versus 5 phases of project management. So with this toolkit actually overlaps the 2 cycles and gives direction into how to run a PCORI project as a project management project. So it's a very pragmatic and a practical approach for doing that. And likewise, community engagement of community stakeholders. We added the stakeholder registries and the details of that.
Yeah, and then there's a little bit of guidance for community stakeholders. I think one of the main recommendations for that was to have a community advisory board. It was very important to have everybody around the table represented as members of the community, so that everybody knows, basically, nothing comes out of the wood, nothing comes as a surprise. Everybody's involved, understands the whole process, talks it through. Recruitment strategies obviously are very important to researchers, particularly lab-based researchers and clinical researchers. So again, it matters that everybody understands the institutional review board processes and the way in which ethics are, the way in which universities are sort of managing the whole ethical process and the data collection and also research delivery. The faith-based messaging, do you want to talk to that?
The 3R model, yeah. So in fact, this is a model that Dr. Padela came up with in his other studies with the cancer and the organ donation and hospice care. And so the 3R model, the PCOR toolkit actually has this model and provides guidance on exactly how messaging and what kind of communication works in the MOSC communities. So there are different components that are involved, and it's a 3-step process: reframing, reprioritizing, and reforming. So the toolkit talks about that.
Yeah. One of the things I really liked in the toolkit as well, and I think Dr. Padela brought this out through training when he was talking about it, is that he'd adopted the model of the known knowns, the known unknowns, unknown knowns, and unknown unknowns. And so things are like the known knowns are things we are aware of and understand. So communities, and of course that could be things that researchers are aware of and understand, but it could also be communities aware of and understand, and things we are aware of but don't understand. And so I think I like that grid. Is that a very nice way of seeing where people have the knowledge, where they have the resources, where they have the understanding, and how that can different stakeholders bring different grids to the table and can actually fill gaps in knowledge by getting together and working out what people know and what they don't know. The things that they're aware of and understand, but also things they don't know, because often you don't know what you don't know. So it's one of those strange things, and researchers can go in circles, just reiterating that. And I think every service group can do that too. You can just think that you get a bit of a stuck on a wheel. So yes, so the highlights really are: engage community stakeholders, think about your recruitment strategies, be aware of the faith-based messaging, think about community-based participatory research within a MOSC context, and really focus on bringing community patient-centeredness to the community. But that is very hard. I just want to reiterate that it's extremely hard. Okay, but the community health workers managed, they realized that, and they worked out strategies to do that. Okay. Fatima, I think you're best placed to talk about this. Yeah.
So MOSC stakeholders, one of the guidance we provide in the stakeholder in that PCOR toolkit is that there are different stakeholders that are associated with the MOSC communities, and there's a core, there's primary, secondary, tertiary, and state, and at the periphery level. So a trained, and this is the beauty of PCOR methodology. It actually, that a PCOR professional, once they become professional or seasoned in the methodology, they're able to bridge the gaps, bridge the communication gaps among these stakeholders. And that is the key in order to develop partnerships and co-learning and reciprocal relationships, which is how things get done. Without these 3 basic principles or 3 basic values, nothing is accomplished. And that's really, I mean, we can keep running in circles, but reciprocal relationships and co-learning and partnerships are the ways how these how things get accomplished. And different stakeholders, and PCORI has a list of stakeholders that you actually possibly saw that with the list where you're a patient or a caregiver, you're a patient, you can be a patient partner, the hospital and health systems, that comes at a secondary level, and but the primary level is the clinician and researcher. So every stakeholder type falls into different categories, and that's how they relate to the MOSC. And when you are running a project in the MOSC community, that's the distance you have to cover with the stakeholder relationships. So the toolkit really provides a good way and facilitates that, and the methodology provides a good way to facilitate that. So I think these are important pieces in there. And then there is a composition. Then we recommend a composition of a PCOR Community Advisory Board with all the different stakeholders on the same platform.
Yes, and I think the key thing is that PCORI has standards for all of these things. So we work. They ask us to report on our meeting those standards, and engaging community stakeholders is a key part of that.
Yeah, I just want to mention that a lot of the times when we talk about a research approach or research methodology, we don't distinguish between the two. However, whenever I've noticed in my experience that whenever they use the word standards, automatically we kind of tend to think in terms of, oh, there must be a standard, so there must be some kind of in writing, which goes against compliance. So for example, ISO standards or JCAHO standards, and these standards come with a booklet, and so does PCORI methodology comes with a booklet. There are 65 standards, and some of these are really beautiful. It's hard not to fall in love with these standards, by the way, if you go through it and if you're into engaging and doing research. So, these are some of the basics that we talk about. My favorite one is the guideline for leaders on communication messaging, and that actually uses the causal inference method, and it tells you about the biases that we internally have and how these biases play a role in engagements. So there is a lot of guidelines through that, a standard for leaders, by the way. And I can go through it. So basically, this is an example that our project where you can find details about. It is this project has 3 basic collaborators, Pastors for PCOR, and Dr. Rebecca works directly in relation to Pastors for PCOR and Worry Free Community both. And Initiative on Islam and Medicine, that's actually the organization by Dr. Padela, and all of his work goes through that organization as well. Okay, and our service areas, basically this is a map one of our intern, Anika Nirala, she put it together for us on Tableau, did a beautiful job. And it shows you the concentration of where most of our communities are. These are the 4 communities where we are doing the town halls, although we do many other areas. In fact, some of our work goes across the nation, but throughout Greater Chicagoland area is where our concentration is. So DuPage County is where we do most of our work. We also do quite a bit of work in Bolingbrook, in North Chicago, in Elston. But we also have, we have recently started working at Al Nahda, which is towards the south side of Chicago. And that's where we have put together a free clinic because of the need that's greater and the COVID numbers that was rising and the kind of calls that we were getting. So with that, you have already gone through some of the timeline. I'm going to turn, this is our last slide. And Dr. Rebecca, do you want to go over it? Because Dr. Rebecca really helped us put together the PCOR Community Health Worker Training Model, and really a great job.
So very quickly, because I think we're a little bit pressed for time here. So we tried to, Pastor and I worked hard to try and align the core competencies which are for community health workers, which are described in the American Public Health Association, and a training, a version of the training toolkit which was suitable for community health workers. And there was a lot of alignment and overlap, which was great. And it was really good to see the emphasis on community engagement and advocacy, which the APHA was emphasizing, the value of the ability to navigate the system, be involved in research, which is again another reason for pursuing partnerships and research engagements, being aware of public concept approaches, the coordination of services, providing the social emotional support within the community without and that's what community health workers, I think, from my perspective, are really valuable at doing, and particularly the community cultural liaison. So the training tools, we adapted it so that people got the best of the PCORI sort of tools, and we based everything on the standards, the PCORI standards, and gave people access to the Ambassador program and the research fundamentals, which are respect, honesty, transparency, and reciprocal relations, really, I think, in some. So yes, I think Fatima, how do we want to shift things around, or
Yeah. So Mary next can go over the virtual outreach data quickly, which is the evidence that we collected through so Virtreach is basically, and I'll give it to Mehreen to take it over from here to give us this segment quickly. And then we go into panel discussion.
Assalamu alaikum and hello to everyone. I just want to thank all of the attendees and panelists for joining us this afternoon. So we had 3 main communication channels for communicating with the community, and they included our hotline, which people could call in at any time, and a lot of times they could just leave a voicemail and then we'd reach back out to them whenever there was a community health worker that was working. And then we also had an online self-help form, so people could go onto our website and kind of put in an inquiry, and we would see that whenever we logged in, and then we would get back to them. And then we also had a live online chat tool, so people would log into the website and they could just put in whatever they were looking for. So if they were inquiring about COVID vaccine availability, we could kind of see that ticket and respond to them if they left an email address or a telephone number to reach them at. So we also went out into the community for different things. So we had this poster, if you guys can kind of see, it's like the purple poster on the right side, bottom left corner. So all of the community health workers were given posters to kind of disseminate amongst grocery stores, laundromats, salons, just different places within the community where we knew that our target population would be. So within these mosque communities, we were kind of tasked with disseminating these posters. So it was a great opportunity to kind of open up that dialogue with store owners, customers that were within the stores, and kind of say, hey, if you guys are seeking COVID vaccines or are have any questions about the vaccine itself, you can give us a call and we can kind of connect you with the resources that you may be seeking. So that was great. I really enjoyed that part of the project, just being able to go out there into the community. So that was wonderful. And then we also, each community health worker could send text messages within WhatsApp groups to local mosque community members to kind of spread word of vaccination events and things like that. And then as Brother Abdurrahman had kind of mentioned, we also had Ask a Doc, in which patients could hear a doc speak to them in their own native language. So we had Urdu and Hindi, Yoruba and Arabic. So patients could hear doctors kind of talk to them about the vaccine or any healthcare questions they had. And that kind of helped foster that trust between the patient, provider, and the community. So that was wonderful as well. Okay.
And gone through this. I'll go over this.
Okay. Oh, I'm sorry.
No, we've already gone through this. The details.
Oh yeah.
Channels.
I already went through that.
Yeah.
Okay. And so here is just a log of the number of calls we were fielding between November and May, which was when the hotline was active for us community health workers. So you guys can kind of see there was a peak in December around the time of open enrollment. So there were a lot of calls regarding open enrollment, and also there was kind of another peak in March when the COVID vaccine went out. So a lot of the calls were obviously regarding insurance inquiries. So a lot of people wanted to enroll in insurance plans because Biden kind of opened up that period again. And so there was that peak in December, and then March, it was kind of a mix of both the insurance and COVID vaccine related inquiries. Okay. So here, kind of, as I had said before, so there were a lot of questions regarding insurance and healthcare coverage. And then that was 50% of all of our calls. And then COVID-19 help, financial help regarding, if patients were uninsured or underinsured, seeking free health clinic access, things like that. Mental health made up a small proportion of the phone calls. And then there were some other various concerns that patients had called us with as well. And so kind of going off of the total number. So there were a total number of 1,281 phone calls. And out of those phone calls, we took out a lot of these spam calls and phone calls that were made by patients repeatedly. So out of unique phone numbers, there were 1,176. And then a lot of these phone calls, we received voicemails, so we didn't include those in the total number of answered calls live, but there were 484 that physically a community health worker had actually picked up while they were manning the hotline. And here we kind of have some web chat data. So there would be people, and this was kind of a learning curve for both our end and the community members, because a lot of people, they would log into the website and we would say, hey, we're here, we're available to help you, and they just wouldn't respond. So there were about, in December, again, there was a peak of 884, encounters with us through the chat box. But a lot of these, either they didn't respond or they did respond and then they just didn't follow up when we asked, questions about what they were seeking help for. But we can kind of see, again, there was that peak in November and December. A lot of it was regarding the insurance and healthcare access. They had questions regarding those things. So then there was also an online self-help form. So apart from the chat box, if community members kind of navigated to a certain section of our website, there was an intake form where we asked for name, email, phone number. And so people were able to say, hey, we're seeking help for, access to the vaccine. Can you help us? Please call us back. And so we were able to kind of follow up with these people and get them the help they needed, which was great. And so we saw certain spikes. So we analyzed all of the phone calls and we could kind of see that a lot of them correlated to some of the community events that we hosted or sponsored. So there was a stakeholder meeting invite that was sent out in December. So like I said, we had a lot of, so we had mosque newsletters being sent out to each of our mosque communities. We had the WhatsApp group. So we were sending all these flyers out via these communication channels. So when we sent out the stakeholder meeting invite in December, we kind of saw that first spike. And then we sent out another email regarding Martin Luther King Day celebrations. So that was another spike. And you guys can kind of see there was a correlation with each of these, flyers that we sent out or any means of communication that we sent out, which means that, our mission was kind of working in that regard. So that was great to see that people were actually seeing these things and it was making a difference that we were reaching out via social media. So that was wonderful.
One thing I got to point this out, I actually sent out the MLK email celebrating the Martin Luther King Day as a test email. And indeed that, so when you touch the hearts of people, you literally make them, you literally can affect their attitudes and their actions. So this was indeed, it was simply a celebration invite, and that gave us almost a similar kind of a spikes that an action item would do, or in fact higher than that. So it tells us that in order to engage people with us, we have to work with what matters to them the most. So it was an interesting test.
All right.
Okay. What is this one?
Yeah, so we kind of went over this as well.
Okay. And a couple of the activities that we were basically. So this is, I can go over this, Mary.
Okay.
So that we actually, on our website, we have a Be on the Map, and this is a resource directory for nonprofit and healthcare businesses that are catering to Muslims. They can sign up for free and they can place the logo, and we are actually calculating how many different types of businesses there are that are, we have about 48 different types of items, for example, elderly care, mental health services, women's health, men's health, pediatric services, financial aid, food pantries. Those are the list of businesses. And when the community members or the healthcare businesses or nonprofits go to this website to sign up, they can select the kind of services they're offering. We normally keep a track of it. So right now we have 70 plus businesses online, and we are growing. So hopefully this can help out the community with respect to, and we also can run a report as to when people come and search for these, we would know who is looking for what kind of service. So we would know the market demand and the community need in the near future. That's the whole idea with this particular website. So hopefully, and now with that, we get into our fourth segment, which is panel discussion. We already have our guest representative, honorary representative, Congressman Sean Casten, and I'll give this back to Dr. Johnson.
Okay, thank you, Fatima. Thank you, and thank you so much to Maureen and Abdurrahman as well. That was wonderful. Thank you so much. And if people have questions, please do. Questions for clarification or Q&A. Pop them in the Q&A, or questions about anything that's been presented in the first sort of segment. That would be awesome. So, having given you the picture and given you the context, given you this sort of introduction to PCORI, and Maureen and Abdurrahman have shared their journey of engagement, as having engaged after some training using the Mosque PCORI toolkit. So that what Fatima and Warifi team did is they put together this wonderful series of town halls, because they wanted to show in action what happens when you bring together stakeholder perspectives from a wide spectrum, which is everybody has different perspectives. We all see problems from different points of view. We all have lots of valuable insights to give. So in this next point, this next section, we invite you to join us in the discussion by thinking about how a patient partner, what a patient partner is in a time of COVID and how patients can help us to improve and understand healthcare treatment options which will benefit communities experiencing health disparities in these difficult times. So it's with great pleasure that I welcome today's panelists, and so using a PCORI sort of nomenclature, I would say that I would welcome Sean Casten from the world of policy decision making, United States Congressman for Illinois 6, and it's also Cara Murphy, who's president of DuPage Health Coalition and is bringing the perspective and insight of the workings of a health coalition in DuPage. And Dr. Mimi Dole, who brings to the table a wealth of experience in engaging community-serving organisations, health, educational and government institutions and coalitions. And like myself, as an independent researcher, I think she's noticing and identifying the need for services. And from reading her bio and looking at her work, these seem to be focusing on asset assessment, program development and evaluation. So collecting evidence, collecting data to demonstrate what works, organizational capacity building and grant writing. And last but not least, I'd also like to welcome Jeff Kubik. And the discussion would not be complete without representation from the world of insurance payers for Medicare and Medicaid and private insurance as well. So one perspective missing is from today's panel, given the talking earlier about the importance of patient-centered outcomes is the patient partner. Remembering Pecori's mission, the goal to help people make informed healthcare decisions and improve healthcare delivery and outcomes. And that is really the interventions guided by patients, research guided by patients is the goal, is the ultimate holy grail, I think, for all of us. So that is an issue, sort of how do we involve people? How do we sort of make those roles meaningful and significant? And so I would very much welcome perspectives from all of the panelists, and to think through and to share. I invite you to share examples of how you have got the patient voices involved in the work, the valuable work that you're all doing. Okay, so if we can move through to the questions that we have.
Actually, can we have Representative Caston open up with the opening remarks?
Yes, absolutely. Yeah, thank you.
Thank you all so much for having me. I'm completely unqualified to be here listening to the last panelists. You all have the legitimate expertise, and I think, to the extent I can offer anything, it's just sort of about the policy range of this. I'm gonna try to stay in my lane, but we are so fortunate to have so many great healthcare professionals and the sort of ancillary services around healthcare, from worry-free community and access health and the healthcare system we have. And frankly, we saw that in the COVID crisis, we consistently had a higher rate of testing in this place than almost anywhere else in the state. We have the highest, I'm proud to say, I think, that the 6th district has the highest vaccination rate of any congressional district in Illinois. But at the same time, I think people who need access to health services would not look at the system we have and say, boy, this is really perfect. I can't imagine improving it, right? So we find ourselves sort of, doing well if you grade on a curve, I guess. And as far as how that affects the policy question, what has been rather interesting and educational and somewhat depressing over the last 12 months is that when we hit this massive national public health crisis, what did we do when we knew that health had to be prioritized? We got testing out to everybody the minute we had testing available and the infrastructure to deliver it. As soon as we had vaccines, we got it out to everybody. We did our best to target it among the neediest and get community health centers out in lower income communities. We changed rules to make it possible for people to take time off and not have to choose between their job and their employment. We took provisions to look after housing. We expanded telehealth so that people could get better access to care. We expanded some of the tax subsidies for the ACA so more people could be covered. And we did all that stuff because on an extremely bipartisan basis, I would point out, because we know it works. And we know that if we, when we maximize public health for all, we maximize quality of life for all, right? It doesn't matter who is getting sick, because the least discriminatory thing in the United States right now is the COVID virus. Doesn't care who you voted for, doesn't care what color your skin is, doesn't care what your income level is. It just cares that you are a warm mass of reproducing cells that it can inhabit, right? And what's nice about that is that we know we don't really have any confusion about the fact that getting to a proper system of universal health care is where we want to go. And yet it's still really hard to get there, right? Because once you actually get to that conversation of saying, okay, what does it mean to actually fix this? You're now having a conversation, number one, that has some politics involved in it. But number two, you have to confront that even if it's easy to know what we would do if we had a clean sheet of paper, we don't have a clean sheet of paper. We have a really complicated healthcare system with lots of different players in it, and you have to think about how you get not from A to B, but from C to B, even if you never really wanted to be at C in the first place, but that's where we are, right? And so a lot of what you're seeing right now coming out of the White House, as far as directionally what they're talking about is the American Families Plan, is a continuation of that. expansions of community health, making some of those Affordable Care Act tax subsidies permanent, making some of the child tax credits permanent, which has a huge impact on public health, because if you can't look after your kids and have to make trade-offs, obviously it's hard to go and get doctors and diapers and all those sorts of things. We did have some provisions in last year's omnibus bill to get rid of surprise billing, which helps because it makes people more comfortable going and calling the 911, calling the ambulance, even if they don't have health care, because they have some confidence about what's there. So directionally, we're moving in the right way, but candidly, it's difficult for me to see that the Senate will take up any of the work we've done in the House until the fall at the earliest, and in the politicization of this. So it's personally frustrating that we know where to go. We've proven over the last 12 months that the ideas that have been kicking around work, but it still is a little tough to get bipartisan consensus to get there. So we will keep pushing, and I continue to just really appreciate what you are doing in the meantime in this imperfect system, but also what you can teach me, teach my other colleagues from your own experience about how to do better. So thank you so much for having me, and I look forward to the questions.
We're honored to have you here.
So actually, I would like to, could I ask you a question? Because I think I was noticing, I didn't mention any of the work that you've done on environment and the climate. And I was wondering whether you think that given the way that, health, we're thinking about research now as being sort of a context, more contextual, social and cultural issues, economic issues. Do you see that the environmental sort of discussions in the White House sort of moving towards thinking about health as well, including issues about health?
I don't think there's any doubt that they're included. I think that the challenge is what you do to get that through, and to act on that information is difficult on a bipartisan basis. And I don't mean to be crass about that, and I don't mean to make this political, but it's legitimately hard to get a lot of folks across the aisle to get behind public investments in public health. Right? If your political philosophy says the best way to allocate resources is for people to, essentially buy things on an a la carte basis, whether that's education or childcare or health, that's somewhat incompatible with public health. So it's hard to get it done. But I think the White House certainly understands it, and frankly, that data keeps coming out more and more every week. I don't know if you saw, we have long known that there is a significant differential increase in premature fatality and asthma downwind of coal plants, to a degree that when you look at what that cost is on the system, it works out effectively to 100% subsidy of the coal industry by Medicaid, in the sense that what we pay as society is roughly equal to the entire revenue of the coal industry. They're shocking numbers. There was a research that came out this week that found, unsurprisingly, that all living things kind of depend on the same metabolic pathways, and that in fact, since the passage of the Clean Air Act, the reduction in particulate and soot and carbon monoxide pollutions has accounted for 20% of the observed increase in corn and soybean yields in this country. Because it turns out that when you have soot coming into those crops, those living things are also healthier without pollution, right? And so now you've got, the health of plants, which of course means that our farmers are producing more food, which means that we've got more access to food at a more affordable price. It's all connected, right? So there's an understanding of it. What's hard is just getting the bipartisan consensus to work on public health.
Okay. So would any of our other panelists like to ask Congressman a question?
I don't have a question for Congressman Casten, although it's great to see you and great to have you here. This is Kara Murphy, and thank you so much, I should say, for all of the ways that you have supported the COVID-19 efforts, both here locally and also from your vantage point in DC. I know that I join others in being very grateful and was appreciative of the interest that you showed in what was happening locally by participating so actively in the conversations that we were having with the health systems and the public health systems to ensure that we had what we needed here in this community. But your comment around the interconnectedness of all of the components of what's happening environmentally and how it engages with our health and the health of our community, in some ways to me seems very germane to the conversations that we have, not only about research, but also about research as it relates to COVID. And one of the very sad lessons that I think people are learning right now, as we all confront a pandemic, is that all of our health is in fact interconnected. That a global pandemic teaches you that none of us can live isolated in this system, and that our health is only as strong as the health of those other folks around us. Our vaccination is only as effective as the vaccination of those around us. And so it's a terribly painful lesson, but it's actually, I think, a fairly effective one, not only about why it matters that we can be concerned about everyone's health, but also why research is so critical. I don't believe that anyone in my sphere, certainly not those that are working outside of sort of clinical and scientific spaces, has ever spent so much time trying to understand exactly what messenger RNA is. You know, care hardly at all about what an emergency use authorization is, or what Pfizer's efficacy is on a particular vaccination. But all of us understand in a different way now and in real time that all of this data has a direct consequence for not only our physical health, but our community's financial health and our ability to continue to function as a society. And so I kind of think that this is a special moment when you think about patient-centered outcomes, because we have not just an opportunity, but almost a demand for the engagement of a much broader array of voices in figuring out how we're going to continue to tackle and overcome the consequences of the pandemic. So I think that is the asset that we are faced with in sight of all of these challenges and tragedies too.
Mm-hmm. Yeah. Yeah. Thank you, Cara. Thank you. Yes.
That was a great feedback, Cara.
Mm-hmm. Yeah. So perhaps if we, we want this conversation to be fluid. So maybe if we move on to your perspective, you know, what from your perspective, what have been the most effective operational changes to improve access to healthcare? Or have you seen some? Have you seen COVID having an impact on healthcare systems and changes to improve access? Because as Maureen's showed so vividly with the slides earlier, that was the question that is getting asked most when people are phoning in. You know, how do I access healthcare?
I think that healthcare today is equal parts push and pull, and I think that historically it's probably been about pull, creating a healthcare environment and then expecting people to somehow find a way to navigate through it. But that's a luxury that COVID doesn't provide to us. And so, for example, using the vaccination effort as an example, it isn't enough to put vaccines at a hospital. Now we are working very diligently on putting vaccines at a county fairground and at a mosque and at a food distribution location, and with my organization in apartment buildings, and figuring out what we do to first understand the barriers that exist and then be really nimble about overcoming them. And you can only do that when you're talking to the community, because you don't have the answers to how to resolve those challenges. It's the community that you have to hear from to create those novel pathways. And so I think all of us are running as fast as we can to try to figure out the best ways to ask questions and then careful to the answers. And Mimi, not to put you on the spot, but you know, that's sort of the work that you do with so much of your research and that we've had the opportunity to do a little bit together in regards to some of this survey work. But I think figuring out how to hear the voice of the people, I would be really interested in your perspective.
Yeah, yeah.
I would absolutely echo what you have to say, Kara, that we don't have all the answers by ourselves. And it's imperative that we do ask the communities we are most trying to serve, and that we do ask communities that are most highly impacted, what are the concerns they have around the COVID vaccine, and what are the barriers that they're facing to receiving the vaccine. And then on top of that, listening with compassion when, you know, we do understand that people have a whole range of opinions about the vaccine, and trying to develop solutions that address those concerns so we can really maximize health and wellness as much as possible.
Mhm. Yeah. So as a sort of community-based, can I ask you a question really? Is that how can a community-based organization working in DuPage develop the relationships which can address health inequities, do you think? What would be the steps?
Yeah, I think the good thing about where we are in DuPage and in the Chicagoland area is that there are so many resources and so many potential partners. So that really is a gift for us where we're located. Things I would suggest were there are so many providers and collaboratives to get to know. So healthcare providers, there are collaboratives and coalitions at most levels of government, from, you know, state to county to local, that folks can get linked with around COVID related issues. There's also a range of, you know, most government health offices are putting out information about best and promising practices. So that is certainly something that we can all be looking towards in terms of, instead of reinventing the wheel, let's look at what works and what has an evidence basis behind it. But also recognizing that we might need to adapt that work, you know, to be culturally competent, to be cognizant of the communities that we're working with. And then I would also say, again, where we're located, there are so many research institutions, so many health-focused institutions that we really could partner with, you know, from researchers at university levels in physical health, mental health, social work, public health, community psychology. All of those professionals have aligned research interests with what we're interested in. So those are some great opportunities for us to be maximizing and elevating that expertise.
Okay, thank you very much. Thank you. I was wondering, in our community health workers who are on the call, what are you thinking about in terms of the future? What would you like to see developed? What sort of is a university something that you think a mosque community partner would be comfortable sort of engaging with and approaching to do with health research, and to collect the data that we're beginning to see is really useful in terms of making decisions going forward? But how do we overcome the ivory tower issue?
Ideally, that would be wonderful. But I think that there is still that degree of mistrust within the mosque communities to some degree. And so it would take a lot of, I guess, engagement within the mosque community to kind of foster that trust, especially when we're incorporating outside institutions, secular institutions that aren't necessarily religiously affiliated. So I think it would take time. I don't want to say it's impossible, but it would just take time, and just you'd have to give it time for that relationship to grow and develop.
Yeah, I agree as well. So it's a very lengthy process, but I think as people get more familiar with, you know, their health needs and what's important for, you know, their everyday lives, it'll be easier. And then also a big thing is, I think in the Muslim community, is like culturally appropriate health services. So like, you know, for females and males like separate, and stuff like the mosque itself doesn't really have like a health, like you would say, a health department or a health representative. So like if somebody stepped up and try to establish like a health representative in the mosque community, I think that would go a long way.
Mhm. Thank you. No, thank you. That's great. So I think that's that's a nice. I actually, Nancy, do you want to mention? I just noticed what you dropped dropped in the chat. So as a mosque community nurse, you facilitated engagement projects. So how would you? What's your perspective? Okay, maybe Nancy can't share.
I wonder if I'm putting her on the spot as well, but I know that Dr. Asfar is on this call, and she and her team have a pandemic health navigation grant
Okay.
that has been focused on community health work in this context, and would be curious about her perspective as well.
Thank you.
Can you open?
Hi, it's Nancy. I'm unmuted, but we're having torrential rain downpour out here, so it's kind of noisy. I think it does take time, particularly in the Muslim community, to establish rapport and trust. And I've been in place in my mosque more officially for about a year, but I've been there for about a decade, making inroads into creating a position of a mosque community nurse, which is really a Muslim faith community nurse, because the concept is new to the community, but it's been a successful model in the Christian community for decades. So introducing it to the Muslim community and making additional adaptations, like adding research, I think is a really good fit. I think there's room for community health workers as well, but having a nurse in a mosque that the community knows and trusts can serve many purposes, research being one of them. Because if your only purpose is research, the community feels, can feel exploited. I'm not saying that they do, but if you have too many research projects in a short span of time, it kind of dilutes the purpose of the mosque, which is really about worship. And so I think you have to be cautious in how you navigate the environment of introducing research as the sole purpose.
Mm-hmm. Yeah. Yes, I would very, very much sort of support that as well. I mean, I think an interesting example is basically a research grant deadline is not an emergency, but so often they are that you get these, emergency or please respond now, and it's not an emergency. So I agree. I think there are, again, the systems are not working together, are they? They're working against each other. So a researcher has to put in a research grant by a certain time. But that can go completely against the rhythm of life in a mosque community. So okay, so I think we've not heard yet from Jeff and the insurance perspective, and I think that's actually really important as well, because one of the things I've definitely learned working with the Worry Free is, like many faith-based entities, mosques are also sort of businesses, and they have potential they can be not-for-profits, but they're very, very aware of business operations and business practices. And I was wondering what steps Jeff thought a community, a not-for-profit, possibly a community organization, would need to take in order to provide services as part of an insurance benefit package, or whether that was even a possibility.
Well, The big
And
answer
while
is,
we go- And while we go towards the insurance perspective, there's another question. Once
Oh,
Jeff has, we want to have conversation around that question. Go ahead, Jeff.
well, Jeff could talk for an hour, so we're gonna have
Oh,
to cut him off at some point.
we have heard,
You've
yes.
talked with me before, so, so big answer to the question is, there's a lot of things good in the system that we have, but we got to get people in the system. Okay, we got to get. I'm gonna take a step back, because Sean mentioned something that would probably help everyone. He mentioned the government got involved in telehealth. Well, we've had very, very little success in telehealth for years, and there was data developing over the years that was a great way to get to more people and give them quality care. Well, with the advent of COVID, it absolutely exploded. And I would say 100%, I'm probably wrong, of the data coming in, it is a wonderful way to provide great care at a better cost. So there are things that we're going to see that came out of COVID that we can take advantage of. A little farther back, there's two theories I thought about what happened to overall healthcare during the duration of the COVID crisis. And the first one is, it's called foregone care. So if you are a geek about this stuff, you saw that actual healthcare costs, or the trend of healthcare costs, went down, right? How can that be? Because everyone was all this COVID and all this stuff. What happened is much care was not done. And there's two schools. One is, and I'm with the foregone care. Those things that were supposed to be taken care of are probably not going to be taken care of. And you saw that with hurricanes and other natural disasters. The other school of thought is that it's postponed care, and we're now going to have this big uptick. What it looks like right now, because the guys who do this for a living, is we're going back to what the normal trend was before. So it's going to look like an uptick, but it's still supports the foregone care, that there's something in the system that maybe you guys can pick up in your community, where these people, whatever they access, I believe, and I don't know this, there'll be research, was it care they didn't need? Did they get something else that worked? Something like that. So that's going to be something very interesting. As far as trend itself, no matter what we do in this country right now, the population is aging, and we're in fact getting better health care through technical means. So we're going to have no matter what we do, we got to understand that the cost is going to go up just on the base of where we are.
Okay.
So I could pontificate a bunch about other stuff, but I should let people ask questions first.
Okay, thank you. Thank you very much. Yeah.
Rebecca, can I speak to the question? There's a question on the slide about community health workers and insurance support for that.
Yeah, please do.
That's some good news. And Jeff may well be aware of this. And if you are, Jeff, would love your perspective on it. But historically, community health work can sometimes be funded through grants, but not typically reimbursed through insurance, certainly not here in Illinois. But there was a recent bill passed awaiting, I believe, still awaiting being signed, but with the expectation that it will be from the Black Caucus, that actually did create a pathway to require that the state create a mechanism by which community health workers would be able to be a billable service in the state of Illinois, at least to our public insurance options. And that is the very beginning stage of that effort. But the expectation is that in the coming years, the feedback that I'm hearing from the state is that they are now looking for, frankly, some subject matter assistance figuring out how to go about doing that in an effective and impactful way. But there seems to be not just an appetite, but now it looks like a requirement that the state figure out and discern a way to put community health work into the remunerated components of healthcare. So that's a first for us and an exciting one.
Yeah, I've heard similar things. It's going to come through the Medicaid and then maybe cross over where you have dual eligible people, and but like in all things, we have to think about costs. So they're going to have specific, this is what a healthcare worker's degree is, and this is what they're doing, and here's the outcomes that it doesn't make any sense to just throw money at the wall, if that makes any sense.
You have to figure out where there's ROI, where you can actually show that there's a return on the investment of community health work. And there's a lot of data that suggests that in the fields of maternal and child health care, in support for individuals aging in place, in some of the substance use disorder treatment. That those are places where there's documented evidence that community health workers can show not just a modest return on investment, but actually a pretty pronounced one. $2, $3, $4 for every dollar spent on CHW work. So that's probably, they'll look for the low hanging fruit first, as well they should.
Right. If you look at what's happening in, let's call it wellness. So there's a big boom where everyone's talking about wellness, and then they've kind of got a misnomer. And what you're seeing in the community-based organization is what the insurance carriers have called managing claims management, where they're identifying classes. You'll see it in the PCORI stuff, asthma, diabetes is a huge one. Right now, when you take a population and find those people that have asthma, have diabetes, keep it under control, that you get an ROI, because uncontrolled diabetes, we all know. And there's industries coming up, high-tech industries, and there's many, many things. So, and I think a lot of that starts from where you guys are doing, but it's not what your community believes, that if I go see a provider, I'm going to reduce the cost of care. It's never happened in the history of our business. Going to visit your provider has never reduced the cost of care, but in any given population. But if we do what we're doing and identify those people that we can help because they have these conditions that we know, if they get comorbidities, I'm overweight, I misspoke. There are 3 things that we have data on that we know you could do in your community, reduce cost of care: lose weight, quit smoking, and exercise. There is study after study. But other than that, we have to identify, we have to get to those people that have some kind of maladies and manage them. That's the quickest way to help your constituents.
Okay.
We have a question in the chat from Brother Hassan Khaja. It's also on the Q&A panel.
Okay. I can't access those.
Okay. So
Is this the question about universal health care?
Yes.
Yeah.
It's on the chat too.
It's on the chat as well.
Could somebody read it out? Sorry, I can't
Yeah.
see.
So Congressman Caston, Republicans have to be told over and over again that if we have a universal health care system, businesses will be relieved of the burden of providing health insurance to workers. This will lead to lowering of cost of manufacture or services and make us more competitive. It will leave bigger profits for the businesses. I think they'd like to hear language of profits for the businesses.
How do I respond succinctly to that? I guess I'd start by saying that as someone who spent more of my life as a CEO than as a politician, I'm very proud of what I did in that line of work, but business per se is not innately moral. Business per se is not innately immoral. Business per se is good at doing business things. It's amoral, right? It allocates capital to projects and creates value. I think there are certainly a quantum of businesses who would love to see themselves not having to be involved in the provision of healthcare to employees, and would advocate for some sort of a public healthcare system to take that away. I think there are also a quantum of businesses who are looking at the current dynamics and saying, if I just stop paying for your healthcare, I can save costs because I don't have any legal obligation to provide healthcare. It's just, I just feel some pressure to attract employees if I can do that. And so, you know, there's probably more businesses going from 90% copays to 80% copays to 70% copays to higher deductibles to moving people onto the gig economy where they don't have to pay any benefits at all, than there are businesses standing up and saying the greatest way for us to save money would be to create public healthcare options. And so while I think your point is completely valid, I don't think that's really the political nexus. I think the political nexus is between a worldview that says that there are things that the for-profit community is simply not really set up to provide, public health being one of them. And we need to make sure that government is set up and funded to provide those services. And in a competing worldview that says the profit motive is a way to differentiate and separate the angels and the devils, because people who make money must be angelic. and you know, and within that, I mean, this goes beyond healthcare, right? I mean, do you think we should have public education, or should we have full school choice where whoever can afford to pay for a really good education gets it and everybody else is left behind? That's the same basic conversation, right? And so that's really the crux of the political debate, not a presumption that businesses feel an obligation to provide this legally, which would go away if we provided something else. Businesses feel an obligation to do this only so long as it helps them attract the best talent. And if most businesses stop providing healthcare, there will not be competitive pressure because an employee won't have the ability to go somewhere else, right? So it's maybe an overcomplicated answer, but I think it's, at least I perceive the fulcrum being a little bit different than is described in the question.
So can I ask a question from a point of view of a researcher? Because I think, what is it? It's interesting hearing, does value-added evidence ever shift arguments? So it's not just proving that something is profitable, or if I can prove that you know, I've got lots of evidence which suggests that, you know, in 10 years' time, if you do this, there will be a benefit. Is that ever going to help shift the policy debate at all? Because given the cycles of government, long-term planning doesn't seem to be priority.
Well, I mean, look, speaking as somebody who, I don't know how to make decisions with that information. Yes, please research, please keep providing evidence. And I would submit to you that in general, we get it right more often than we get it wrong. On the other hand, Winston Churchill was right when he said democracy is a lousy form of government, but for the alternatives, right? The nature of 2, 4, 6-year elections, is a little hard to fit that into a 10, 20-year strategic plan. Yes. The Chinese government is very good at doing 5, 10-year plans, right? But you sacrifice a lot of that, in terms of the vibrancy of a democracy. I had a conversation with Speaker Pelosi a few weeks ago, and I said, the longer I'm in this job, the more respect I have for the system of government our founders created, and the less respect I have for the management structure they created in order to implement that system of government, right? And so yes, that information matters, and people do think in those terms. But I think you're right to be somewhat anxious about, our political process doesn't always facilitate long-term planning. Although we do, I think, in general, eventually get it right. But ultimately, the way to make sure that happens is not by saying, politicians, why won't you do this? But by putting it on voters to say, why won't you elect people? Yes. who will focus on those long-term goals, right? Because with good people in positions of power, it'll all get factored in. There are some of my colleagues who I wouldn't necessarily put in that description.
Okay, thank you.
Yeah, and I do think that when we keep this patient-centered goal as a focus, no matter what a strategic plan we have or which government comes and goes, it's basically in the midst of healthcare, we have this patient-centered philosophy that we all follow, and that kind of keeps it keeps a straight path for everyone to follow. Basically, it's a vision. And it's unified vision. That's how I feel about it.
Yeah.
So how do we as community health organizations can support each one of the sectors here?
Can I just make an observation that some of this is sort of, I think, and we're all, or at least a lot of us on this call, are also employers. And one of the most interesting things that I heard over my brief 2 years, I had the privilege of being a freshman of Congress in 2008, along with Donna Shalala, which, was funny. Here's this woman who was the head of the Health and Human Services Department, who had been the president of the University of Miami, and now she was a freshman member of Congress with me. And she told me that when she took over University of Miami, she realized that all of the opportunities and challenges she saw when she was running HHS, where she had to get through this consensus-driven government process. Now she was the president of the University of Miami and was responsible for designing a healthcare system for a whole population. And the buck stopped at her desk, so she could just do the right thing. And one of the things that she said they did was they immediately said, okay, for all the people who are self-insured, we're going to get rid of copays. Because she knew in her heart of hearts that the way that you get quality care is you take away any marginal economic disincentive for people to access care. And she said it made a huge difference that the quality of care went up and their cost of the overall system went down. And because she had the ability to do that. And so, I put that out to people who are on this call who may have the ability to manage systems of their own, that the incremental decision about how do I cut the costs, we all have some responsibility for thinking about what is the 10-year consequence, right? And that's just as true in corporate boardrooms as it is in Congress. And for those of you who are in positions of great power where you might have that longer term planning horizon, follow Donna's example. You might be able to do some cool stuff.
Okay. Are there any more questions from either from panelists to panelists or from people on the call?
I would just like to say thank you to Fatima and to Dr. Johnson. One of the things, I'm a huge fan of PCORI, and one of the things that I think it's hard to get people excited about research, right? You know, this is the battle that you guys are fighting, and oftentimes people's perception is that it is dry. But for us to, I want you to keep fighting that fight, and the reason is because making certain that all of our community is informed and comfortable digesting data and sifting good data from misinformation is so important right now. And there's an awful lot of really smart people that are still struggling to figure out when something that is being told to them is accurate or when it is misleading in one way or another. And that's really the promise of becoming a research savvy community and a research savvy population, that we can be much more discerning and figure out when we should be trusting and listening to data and when we should be questioning it because it just doesn't really make sense or it doesn't really speak to our experience.
Yes. Yeah.
Thank you.
Thank you, Kari. Yeah, thank you. I really passionately believe that too. I think one of the things is that as we move into a more of a sort of digital world, we are sharing more data as well, and we need to be very, very aware of how it's used. And I don't always think members of the community necessarily ask what's happening to my data, or people make assumptions about what's happening to it. And you can't just always assume bad things are going to happen, but you do need to know what's happening, don't you? You need to be informed about what's happening. Okay, Fatima, so I think
any other, we have come to the end of time. Any if Jeff and Mimi has some final comments?
I just appreciate you inviting me. This is always wonderful. You guys are doing a great job.
Thank you, Jeff, and we always would love to hear from you.
Yeah, thank you so much for hosting. This is so needed.
Thank you, Mimi. Thank you, everybody. Thank
you so much.
Yeah, thank you very much. And yes, much appreciated. And I thought it was a very valuable discussion. And thank you so much to all of this community, the workers who presented, and also being part of such an amazing group to work with.
Yeah, I just want to acknowledge lastly, just want to acknowledge some of our key members, the project team, of course, and the MSI community members, Brother Asfar, Brother Nadeem, and Brother Shabir. Of course, Dr. Rebecca Johnson, always much appreciation goes for you, and Dr. Asim Padela, our community health worker team. Especially, I want to have two more people, Anika Nirala, who's helped us with putting the graphs together, and our technology expert, Usman Mughal with Orbit 360, who has helped us put the data together. So thank you again for everything, and I hope to hear back from you and keep in touch. and as we move forward with the programs, you'll definitely be hearing from Worry Free Community. And
I want to thank Fatima, who's absolutely amazing. So it's just full of energy and just always has ideas, and it's just a lovely lady to work with. So thank you, Fatima.
thanks, Dr. Johnson.
Thank you.
Thank you.
By the way, I just want to mention for the last thing that our upcoming 2-day symposium would be on September 18th and 25th. And you would definitely hear back from us with pretty much recapping of the whole project and the next steps from this project onwards. Thank you again, Congressman and Kira and Mimi.
Yes, enjoy your weekend.
Enjoy.
Yes.
Thanks for having us. Have a great day, everyone.
You
Yeah,
too.
bye.
Have a good one.